You have 1 minute left. Yes, your countdown started. So, yes. So, time over. I'm going to end this poll. Thank you so much for all your active participation. Let me share the results, and I invite Dr. Pari to share the share this poll results with the audience, Doctor.
Thank you, Stella. Thank you for the introduction. And welcome everyone back to our Friday afternoon webinar. And this poll is about the practice of critical results management. The first question is about awareness, and as expected, a majority of our audience, 88%, are either very familiar about or somewhat familiar about the whole topic. And a minority have said they're limited or not familiar. The second is about the experience. Have you encountered or witnessed a delay in critical lab results? So again, you can see that almost 1/3 of the audience have said they encounter this critical lab results quite frequently. And so this is quite a common occurrence in busy hospitals. So I think this is very interesting. So what is the biggest barrier to timely critical lab results communication? And it's actually spread evenly among the first three choices: unclear responsibility and accountability, communication, technology, and heavy workload. So if you look at it, most of it is related to the personnel, how the training is and how you train them and how they are actually communicating with each other. So this is a very important part of critical lab results. It's not about technology, it's actually about our awareness and training. And the fourth question is about the formal training. It's actually a follow-up to the third question. So again, 1/3 of them exactly have comprehensive training. Other third, some orientation, and a few of them have learned on the job, and a small minority have no training received. So this is very important, and it's glad to know that almost 60% of the audience have some sort of training on this. And here comes our famous movie reference. So the majority have chosen the Three Idiots, miscommunication during delivery scene. Yeah, I think that happens often. But I was surprised about 40% and ignored iceberg warning. So the lab, I think there's a lot of lab people here. So they are saying that in spite, or maybe nurses, in spite of the warnings given, either the clinicians, including the nurses and doctors, are not taking note of this critical result. So that's something which is quite interesting. And delayed problem recognition and a small percentage. So thank you so much for your enthusiastic participation in the polls. So let's move on to the next part of our webinar. Thank you, Stella.
Yes, thank you so much, sir. So let's start this session with the scenario. So it is 3 p.m. A lab report we are going to talk about. So here's a patient, Mrs. Lakshmi, who's 68 years old, admitted with severe weakness, and her critical lab results were sodium 110 milliequivalent per liter and potassium 2.8 milliequivalent per liter. So the report sat in the system for 8 hours. No, so it is not moved forward. So by 11 p.m., the patient developed confusion and seizure. So this is the scenario. where we are going to dissect today, and we are going to see what what is supposed to be done for this patient Lakshmi. So here, so we'll be walking you through understanding the critical lab values. So what makes them critical, and the case scenario discussion. So walking you through the 8-hour delay and root cause analysis and finding the why behind the real reason behind this incident, and building fail-safe systems like immediate action and what are all the corrective action, preventive action to do, and to standardize the workflow to prevent such delays in your healthcare organization. So what are critical lab values? Let us understand the basics, then we'll move on to the in-depth knowledge about those. So life-threatening results. So here on the right-hand side, you can see an image of a few which we have mentioned the critical values like sodium, potassium, glucose, creatinine, INR, and troponin elevation in chest pain. So these are all the reference points where we are taking this as a critical values. And when it comes when it comes to you, to your knowledge, this patient have such critical lab value has been arrived to your department. So you have to take an immediate medical intervention, because if we are delaying it and it leads to the life-threatening situations, so value is so abnormal that delay could cause serious, like even the patient may end up in sentinel events. Every facility must have a list of critical critical lab value alerts, like even in your nurses station, in your departments where you're doing your documentation work, the list of critical lab value must be displayed, or it should be saved in the system, so that when the value arrives, even a novice nurse knows how to handle that and what has to be done. So why it is so important? Because abnormal results, as I've said, the delay increases stay likelihood by 33.6%. It's going to extend the length of stay of the patient, because we are not going to do the medical intervention on the right time. Then the patient is going to get sick, and the treatment which is going to be bit delayed, the patient is also going to be in the hospital for a longer days. So communication failures also contribute to the sentinel event. So we know this is the critical lab alert value which you have reserved, but you do not know how to communicate this or to whom to escalate this value and what has to be done. So we'll be you will have a detailed explanation about this, what has to be done, and timely notification. Like you have received it and you know what has to be done, but it is not done at the right time. Critical lab alert you have received, you have to react immediately. You cannot put that on hold and you take care of another patient and come back and escalate that. It is also a wrong thing. It has to be on to the right time. If you're not doing it, then it will be like increasing towards the morbidity, mortality, and the treatment delays. So we have the mnemonic here, the closed loop. The loop is not closed until all steps are completed. And every facility should meet this written protocol following this framework. So we have one for the example. So C stands for confirm the critical value and patient identity. And L stands for locate and contact the responsible provider immediately. Like if you have received the critical value and you have to identify whether this critical value belongs to this patient, you have to identify the patient. First, you have to complete that basic part. Then you have to contact that responsible provider. That immediately you have to call the primary consultant. So as per your hospital protocol, whom you will contact when you have received, but as per the standard, you have to contact your primary consultant. And O stands for obtain the readback confirmation from the provider. Once you have received or you're receiving the critical lab alert through the phone from the lab personnel, then you have to follow the readback method, which is nothing but you should not repeat it back. Like you have to write down the value what the lab personnel have told over the phone, and then you have to read it back to that person so that the readback communication is followed properly. And S stands for set correction process in motion, like who, when, and what has to be done. And what is done, and you have to do that documentation things completely. E stands for execute documentation in the critical lab register. So you have to do the documentation in your patient file, and also you should have a separate register for the critical lab register. For example, what are all the values? If it is critical lab values you are receiving, you should have maintain a separate register. Many hospitals are moving towards the technology. If you have your in your digital system, then you have to upload in your system. So whatever the method you follow, but the tracking must be there. So once you have received, you should document in your notes, and also you should document in the critical lab register or in your system wherever you follow. And D stands for doctor or nurse order must be evident in case sheet. So what the nurse have reported to the doctor and what the doctor have given you the the interventions to be done for the patient must be documented clearly in the nursing document. So doctor, do you want to add something in this, or
Yeah, I think this is documentation is very, very important, and documentation follows the the process, right? So once the person in the lab gets alerted of a critical value, then they call either the nurse or the doctor directly. In case of OP, they will probably call the doctor directly. But in the IP, they will talk to the in charge nurse or the nurse, where the ward the patient is. And the lab, no, the lab person's responsibility ends there. But then the responsibility shifts to the nurse or the doctor who have received the information. And they should document that the time at which they received the information in the case sheet or in your electronic medical record. And then the nurse, if they have received, then they have to contact the doctor, and the doctor will give the orders, and the treatment should be initiated. For example, if it is hypokalemia correction or hyponatremia correction, or if the glucose is low, maybe you gave some either dextrose, or if it is high, you gave insulin. So all these corrections should be documented in the case sheet. So when we come to assess, any assessor comes to assess the critical lab process, critical value process in your hospital, they will do this. They will go to the lab, look at the critical register, pick up some few case sheets and MRD numbers from that, and then ask your MRD to bring in those case sheets and also check those case sheets to see whether the loop is closed. So that is why here we are emphasizing on this loop, and it is called the closed loop. So closed loop is always, emphasized in communication. You have to close the loop, and very, very important in critical care values.
Yes. Thank you, doctor. So this, let us take a deep dive into Mrs. Lakshmi's case. Hour by hour, what, like lab completion. So lab results were finalized at 3 p.m. So attempted the call. A call was made by lab technician to the ward at 3:15 p.m. But the ward line was busy. So shift change was happened. So at 4 p.m. causing a handing over gap. And then what happened? You can imagine. So the lab have finalized the report of Lakshmi at 3 p.m. and call was attempted at 3:15 p.m. and the shift change occurred at 4 p.m. So this is what happened at Mrs. Lakshmi's case. So 11 p.m. night nurse notices patient confusion, checks reports. So here the serum sodium 110 milliequivalent per liter. So and also serum potassium 2.8 milliequivalent per liter. And clinical risk, the patient obviously will end up, because sodium and potassium have a tendency to cause the destruction in your normal being. So seizure, cardiac arrhythmias, altered consciousness have been occurred to this patient, and patient required immediate IV electrolyte replacement and monitoring, but it has not been done because at right time they have not received the report because of the communication delay. And what should have happened? The ideal pathway, lab identify the critical value, and also they have documented in the critical lab register, because this has been before some time Dr. Pari explained you this pathway, how it's supposed to be. Once they know this patient has this critical lab value, they should document in their own lab register, and directly they have to call to the ward, because the patient obviously admitted in the ward. So the direct call will be to the ward nurse with the readback confirmation within 15 minutes, and nurse immediately supposed to inform to the doctor, and they are supposed to document in the case sheet saying to whom they have informed, what they have informed, and what is the immediate intervention given by the doctor. So in case of here, IV electrolyte replacement might be the treatment for this patient. So treatment begins within 1 hour of time without any delay. This is actually supposed to be done for the Lakshmi, which is actually missed. So here we have one interactive element for all our audience, like what were the key breakdown points in this case? So I have taken you through the scenario, right? So from out of that, what is the key breakdown points? So whether it is option A, option B, or option C, like only the phone line being busy, or lack of escalation protocol after failed first call. C is like inadequate shift handover process. What would be the reason? You can drop down your answers in the chat box. Yes, B.
Can be more than one also.
Yeah, more than one also. Yes, you're right. B and C. Okay. Good. A and B. Okay. Okay. So some are saying B and C, and some of them are saying like A and B, and quite a few are fixing to option B. So let us see with the scenario. What we have discussed is like B and C, like lack of escalation protocol after failed first call. Like the lab personnel have called that ward, and they have not attended to that call. Then obviously he is supposed to do something. Second thing, what he is supposed to do. So he should have some workflow. What is supposed to be done, to whom he has to escalate, but it is not done, right? And C is like inadequate shift handover process. So the two are the reasons. Single points of failure, never the whole story. So they should have a backup protocol if something is failed. So what has to be done like next? So that protocol is missed out. So for the common communication failure. So over to you, Dr. Pari. Take us through the root cause analysis and finding the real why behind the scenario.
Thank you. So one of the things which we emphasize in quality is an incident report or a root cause analysis is not to blame somebody or fix an error or someone. It is to understand what is wrong with the system. So the system problem is most often the cause. Individual errors are very, very in the small proportion. So this is something which we need to understand. So next slide, please. Okay, so what is root cause analysis? Basically, we need to have a systematic approach to identify the underlying causes of incidents. So in this case, this particular scenario, what we are discussing is called an incident. So incident is something which, is something which has caused either harm or which could have caused harm to a patient. So that is what we call as an incident. And here, once an incident happens, we need to not just go for a quick fix. We need to have a systematic approach to identify the underlying cause of the incidents. And as I said, you look more at system causes than at individual blame. And you use several structural tools like fishbone diagrams and 5-why analysis. It is said for any quality professionals, I'm sure there are a lot of quality professionals in this audience, there are there is almost a set of 5 to 7 basic quality tools which they have to use. So some of these tools may be just to find out what is the cause. This could be like a checklist which you do, for example, fall prevention checklist and all those things. So that could be on also called as a quality improvement tool or quality analysis tools. The second is to analyze why an error is happening. And that's where this fishbone diagram or Ishikawa diagram or 5-why analysis come into play. And then there are other analytical tools like the Pareto chart and the run charts and all those charts. They analyze the data and find out, in the Pareto chart, you look at the vital few. Then, looking at all the causes, you can, nicely tabulate the causes and find out what are the top 20%. And that is the Pareto analysis. So like that, there are several tools available for you to do, analyze any incident. And the whole goal, why it is called root cause analysis, is you have to create a system change so that this incident does not happen again. Ideally, it should not happen ever again in the institution. So that is why the after root cause analysis, the action you take is known as the corrective action and preventive action. So usually, this is told like RC and kappa. And usually then in the meeting, all of us have a cup of coffee. So people think that kappa stands for cup of coffee. Okay. So CA stands for corrective action. So corrective action, in fact, has two components. One is immediate correction. So in this case, when a patient has got low sodium or low electrolytes, like potassium, the immediate correction is you have to give them that electrolyte and bring the electrolyte level up. That is, first make the patient safe. So the next corrective action is in that area, you have to find out why is that, lab person did not take the efforts to escalate it and give them training. Tell them the importance of what a low sodium or what any critical value can cause, and try and correct it in that particular area. For example, in this lab. So this is corrective action. Now, preventive action, what you do is to make sure that this particular incident never ever happens in your hospital again. So for that, you need to look at the whole hospital and make sure that the communication systems, your documentation and training is given to all the responsible people. So once you do that and then keep doing regular audit and PDSA cycles to make sure that this preventive action is ingrained into the system so that it doesn't happen again. So this is the whole purpose of doing a root cause analysis in kappa, so that these incidents do not happen again. So here, for lack of time, you're going to just highlight only a couple of these quality tools which I spoke about. So this is the 5-way analysis and the Ishikawa and the fishbone diagram which you're going to talk about. Next slide, please. So let's look at the 5-why. So the 5-why is a technique by which you keep asking why 5 times so that you get down to the cause. So if you just ask one time, you will only get a superficial answer. What is known as the apparent root cause. So when you keep on asking more and more whys, so mostly by the 5th why, you will be getting down into the real root cause. Sometimes you may end up in 3 whys, or sometimes you can go up to 7. So there is no strict, like you have to stick to only 5 whys. It is generally called 5 whys. It is also known as the 2-year-old method. So usually these 2-year-olds, they keep on asking why is the fan running this way? Why is the light burning yellow? They keep on, they're so curious. So you have to bring in this curiosity into yourself and keep asking why. So you come down to the root cause. So when we ask the first question, why the lab could not reach the ward nurse? So the answer is the phone line was busy and there was no alternate number. Therefore, the lab could not inform the ward. So why the phone line was busy? So maybe there's a technical error, but could you have actually informed in any other way? Yes, but there was no escalation protocol, or the protocol was not known to that particular person, or maybe they disregarded it. So that is the cause for the next answer to the next one. So why there were no protocols? Why there was no escalation protocol? So it is either because the protocol doesn't exist at all, or maybe it exists, but the training was inadequate. And here is why, which comes down to the quality department, which I don't think may not be the right answer. Finally, the quality committee review of critical value communication was not there. So it is right in a way. It is correct. Now, if I, as a member of the quality department, I had been very watchful and made sure that I'm looking at all the critical value communication even before and make sure the training had happened. This wouldn't have happened. But you also have to look at the departmental level. So basically, it's a system problem where there has not been enough protocols to in place to prevent such errors. So one of the things, many times people ask me, how do I know whether I am asking the right why? So one of the ways in which you can find out is asking therefore and going backwards. For example, now you take from the fourth why, protocols were not developed or staff was not trained. Therefore, there is no escalation protocol existing. So therefore, when the phone line was busy, the ward was no alternate method was used. Therefore, the lab could not reach the wardness. So now you know you are on the right track. So always, when you put down the 5-way analysis, go from the bottom upwards asking therefore. Then you'll know. Anywhere when you ask therefore, the answer does not fit properly, then you know you're not asked the 5 why. So this is something very important you have to keep in mind. So ultimately here the root cause analysis was lack of protocols or lack of quality department's oversight, which was responsible. Next slide, please. Okay, I think you have to keep clicking. Okay, now the other quality tools. So these are the two most common tools used by most quality people. So that's the reason we thought we'll highlight this. So it is also known as Ishikawa. Ishikawa is the name of the person, a Japanese quality. He's actually called the father of quality in Japan. So actually, very interesting story is Edward Deming is actually known as the father of quality world over. So Deming actually was from the US, and he, had all these quality principles which he learned. And at the time, the automobile industry was booming. Ford and other, things were producing automobiles. So he went to the American Ford company and all that and said, I will teach you quality, and you can make high quality cars. So they were not that much interested. At the time, Americans were more interested in output. They were interested more in how many cars they can make in a day. And Deming's intervention would actually bring down the output. So they said, no, get lost. We are not interested in this. We want to make more cars. So he went to Japan. I mean, I don't know how he landed up there, but he ultimately went to Japan. And there, people were very keen to listen to him. And one of them was Ishikawa. And he got in Deming's principles and put them into the Japanese, what is now known as the total quality management. And a byproduct of that is the Toyota production system and all those things. And the Japanese automobile industry incorporated all these into their manufacturing. And that is how the Japanese cars just rule the world now. We no longer now we go for American cars. We only go for Japanese cars. So this man, Ishikawa, was the father of quality in Japan, and he was responsible for all the other things which happened afterwards. So one of his major contribution is this cause and effect diagram, which he used to call it with the cause and effect. People later called it Fishbone and later called him by his name. So this is very, very useful because it helps to the team to brainstorm together so that they don't miss out any factors. So 5Y just looks at one or two causes, whereas the cause and effect diagram will look at the whole picture. So let's look at the same scenario and see what are the other factors which was responsible. Next slide. So here is the fishbone diagram. So there are several ways or captions which you can use. Here we use the man, machine, method, environment headings. And the head of the fish is the effect, what you have seen. Failure to communicate critical lab results, you first write it down there. Okay, then you get into each of those things. Man, again, there is a gender bias here. My daughter would be very angry if she sees that. So that is why the P's are P's are better. So they call it person, no, instead of man. So in the person, the lab tech was unfamiliar with the escalation. In the ward, maybe a new nurse was not trained. And the method is the process. So there is no backup communication, no written escalation protocol, weak shift handover, undefined time frames. So these are all the defects in the process. And in the machine, which is the the equipment or the infrastructure, or what is known as the paraphernalia, there is only a single phone line. There is no backup communication technology. And again, in the environment, maybe the ward was very busy, high noise level causing distraction, so that you can go on. So you need to know what are all the causes. So you can see, if you want to do a quick fix, you do the 5I. If you want to look at all the causes, you do a cause and effect analysis, and then use the Pareto chart to look at the vital few. That is the top 20% of these causes, because you can't fix everything together. And also, a Pareto chart is also known as the 80-20 rule. It is said that the top 20% is responsible for 80% of the errors. So if you fix those 20, 80% of errors will get fixed. So that is why these three tools at least you should know: the 5-way analysis, the cause and effect diagram, how to do, and how to plot the Pareto chart. There are many others you can add on later. Okay, so here you can see a whole picture of what are all the defects which lead to this effect. Next slide, please. Okay, so now that you know the root cause, so how do you build a system so that you have a fail-safe system, that preventive action? So do you want me to go ahead, or Stella, you want to take over?
Yeah, you want to go ahead? You can go ahead.
No, you carry on.
Okay, so I have an announcement before that, Doctor. So that is, I have two announcements. One is we are having an upcoming infection prevention and control webinar, ICN webinar. It's a free webinar that we are going to focus on the topic practical infection control risk assessment, which is also called as ICRA. Okay, and it will be on 17th December, 3 p.m. to 4 p.m. So speaker is Miss Gokila. So she's oh my God, many hearts are running on the side. I don't know, is this for Gokila or for the announcement? So Miss Gokila, she's Deputy General Manager and Infection Prevention and Control from Dr. Rela Institute and Medical Center. So you can scan this QR.
I think, yeah.
Yeah, I think so. So you can scan this QR code and you can, get benefit of this program. Since last month, we have started this infection control nurse webinar. To ideally, we thought we will be like addressing only the ICNs, but it is open for all the nurses, administrators, doctors, and who all are like working closely with the infection control department. So you all can come to this free webinar, get benefit out of this. Last month we focused on the topic outbreak investigation. So that was a great hit, and we are expecting the same like number of participants. You can come, join us, and equally benefit out of this session. So then the next announcement, so it is a live Zoom masterclass. So healing beyond words, so empathy and effective communication across the hospital journey. So you're going to have a good masterclass. That's from Ankita Beagle. So she is a healthcare communication trainer, AGM process training and audit, and also she's from Sharpsight Eye Hospital from Delhi. So this is going to happen on 24th December 2025, and it's from 3 p.m. to 4:30 p.m. It's a 1-hour masterclass program, and it's a paid webinar. 1.5 hours, sorry, 1.5 hours. It's masterclass, and it's a paid webinar. So seats are filling fast. You can book your slots now. So, and also for these two announcements, already we have shared the flyer in the WhatsApp group. You can register from there. At the end of the webinar, again, we can also reshare, because many new members will be adding to our WhatsApp community. Someone have raised your hand, like want to ask something? Maybe we'll hold it for the last, towards the end.
Yeah,
We'll have any questions? Yeah, okay. Yes. So as Dr. Pari have said, like we have immediate action when some incident happens, and also we should think about the kappa, which is the corrective action and preventive action. So like immediate action, what has to be done for Mrs. Lakshmi is like electrolyte correction, because the orders, like the communication might have got delayed, but you don't have to think what you have to do for the next, when you the moment you know, like the patient has the critical lab alert and you have got the interventions from the doctor, you have to straight away start the treatment. So IV electrolyte replacement, and you have the incident has to be filed, and all the incident, not only for the critical lab alert, whatever the incident happened in the healthcare sector, it is supposed to be reviewed within 24 hours by the quality committee team, and also all the laboratory and nursing staff briefed on the incidents. So for me, I would say if any incident happened in the healthcare sector, what you have to do is like, you don't have to focus on the mass training. First of all, way the incident have happened, you have to focus on the on-the-job training. So when you focus on this incident, this is actually who all are involved in this incident is the the lab personnel, the entire lab department, and also the particular ward. So what is supposed to be done is like focus on the on-the-job training, give the brief about that incident, and then give them the on-the-job training so that the future incident we can prevent it. And also they will understand what went wrong and how, like what they are supposed to do for this patient, and where they have failed in the system. So that is actually ideally you have to focus on. Don't focus for mass training. Immediate action is the on-the-job training, and temporary emergency protocol can be implemented. So we will see step by step what is supposed to be done here when such kind of incident occurs. So immediate correction is like corrective action is a short term, which is not like we are focusing on the least implementation methods, like fixing an immediate gap, developing a written escalation protocol, 3-tier contact system. So maybe the lab personnel doesn't know if this call is failed, whom he has to contact. So you can give a written protocol, escalation protocol, so that in for 30 days or for 1 month of time, when you go for the advanced level of implementation, before that the lab personnel or the whomever the concerned department can use this written escalation protocol. They know what has to be done next if this call is getting failed, and creating a critical lab register with mandatory documentation field, and also instituted the readback confirmation requirements. So they also all the both departments has to be, or the departments in the hospital has to be aware about how the readback is supposed to be done, and enhance the shift handover checklist to include pending critical items. So because we have failed in the communication, and also we have failed in the handover process. So what is actually, when you're giving a handover, you're following a 𝐼𝐴 method where we have discussed in previous webinars and all. So in the recommendation part, you can have another point saying that what are all the pending critical items supposed to be informed to your next shift colleague. So it has to be included there so that without fail, you can inform them. So this is can be done within the deadline of 30 days because it's a least priority. You're not going to spend, or your management is not going to spend much cost involved in it. So the technology wise, you can do some corrections. These are all the many good practices, best practices, which is done in many hospital in the digital wise. So many hospital has all this 4, and certain hospitals have 1 or 2. So we would like to discuss about this is like implemented the automated SMS alert. So all the things are automated now in the hospital like IT sectors. Like if any critical lab alerts are happening, like immediate SMS alert directly goes to the doctor's phone, so that the time period which you are taking to inform to the doctor is saved. But still the phone communication is supposed to be done, but meanwhile the doctor will get the immediate alert over his phone. And also added electronic flagging in hospital information system. So it's in like, if in your hospital system you're following your digital system, you're following all your patient data flow, everything in your system, so that the alert will be given. A warning symbol it's shown in this image. The warning symbol will be there on your display. So it gives you an alert saying that one patient is have got their critical lab alert or some deviation, and there even in the vitals, if deviations are there, it gives a critical like alert on your system. So that's how you're going to note that particular patient is having, in this case of scenario, like particular patient is having a critical lab alert. Okay, so this is the time to communicate to the next person. So then third thing is like created backup communication via hospital WhatsApp groups. If particular department is not attending to the phone call, how to communicate, to whom to communicate? You can have a common WhatsApp group where you will have all the departmental heads in that group, so that if you put that alert, if the in charge have missed out the information, then the supervisor might be getting that information, and they will call them personally and then alert them saying that you have missed the call from the lab department. So, this patient Lakshmi have got the critical lab alert. Immediately call to the lab and get the things done. So this is the created backup WhatsApp communication. And also the fourth thing is about set up real-time dashboard showing pending critical value notifications. So now it shows this is also moreover the technical part, like it shows the patient trend itself, like how they were. Am I right, doctor, about this? The fourth one.
Just that it comes up as an alert. I think that's
yes.
on the dashboard. You could see the TAT. There is
Yes.
a turnaround time,
Yes.
trend over time, how quickly you are responding to critical values. So that is, more quality managers' perspective, they can look at it.
Yeah, okay. So this is all about corrective action, and it takes some time. So that is why I told the least priority things are like written protocols, escalation protocol, which is very minimal. Cost is not involved. But when it comes to corrective action, technological aspect, it's a long-term thing also, and it involves some cost because we are involving the digital things. And preventive action is a long-term. So you're correcting your entire system. So monthly audits of critical value communication. So what is supposed to be audited, like doctor have explained you, like how the NABH assessors will do the audit. You don't have to wait for the assessor to come to your department. As sir have told, you can take an initiation, you can fix the auditors internally, and you can go to the lab, check the lab register, and take one of the files from your unit and check whether the loop has been closed when it comes to critical lab alert, whether they have communicated to the doctor, read back is followed, and you can do the you can get the track of all the entire document, and you can see how the things are working well. So this is you have to include the monthly audit, and also quarterly training for all the lab and clinical staff. So how you are doing a mandated training for infection control, and also for the fall risk assessment, IPSC, these all are like included in your mandatory training programs, of course, in all the hospitals. So the same way you have to include this, the critical lab alert training as an important mandatory training in your organization. And also annual review and update of critical value panel list. This will be done by the team of members who will be involved as like quality personnel, the nursing department, lab personnel. They will have an annual review of all the critical values, and also whether the things are tracked well. And establishing a quality committee oversight with incident trend analysis. It is like about the incident. After doing all this implementation, for example, implementing the technology, how the practice were, and before implementation, how many incidents were related to the critical lab alerts, and after implementation, whether the critical lab alert related incidents have come down or not. So this quality analysis will be done by the the team members involved in the quality team, and also in the department of lab and nursing. So this is about the corrective action and preventive action. So this is all like, the preventive action is, it's a continuous improvement. If still there are incidents occurring, then you have to see like what went wrong and what can be implemented more to prevent such incidents. So the mnemonic, here we have another mnemonic is about safety. Standardize your critical value list. You have to keep it updated. So that's what you have to make all your healthcare professionals who all are involved in this kind of care involvement. They should know what are all the critical lab alerts. They cannot memorize it, but on and off, if you conduct the training, they will keep them updated. And then alert immediately, like using multiple communication channels. And F stands for follow the closed loop protocol for every single time. And E stands for escalate when contact fails, have backup protocols. And also T stands for train your staff regularly and document the competency. You have to, and Y stands for yes to documentation. If it is not written, it did not happen. So if you're not writing it and telling it verbally that you have communicated, you have done for this patient, this interventions are done, it is not taken as you have done for the patient. So you have to document it. So that is why doctor was explaining about like closed loop, why it is so important. So we have come to an end. So yes, for this webinar, we have the handouts. As we had a lot of announcement for this webinar, we don't want to show the QR code here again to confuse you all. If the participants who all are interested to get this handout for this webinar, it's a paid handout. You all know many of our participants would have got the handouts for previous webinars and all. So you can contact our admin manager, Jayanti. So Jayanti, you can drop down your contact number again in the chat box. Interested people can scan the, you can contact Jayanti. She will send you the details how to get our handout. And so today we have gone through this critical lab values and life-threatening treat them as emergencies, why it is so important, and also how to use the closed loop framework for every single critical value update, and also how to apply the safety principles. So you have to standardize, alert the personnel, follow the protocol, and escalate your concerned department, and train your in every individual healthcare professional, and yes to documentation. And also system fails, you have to rely on single points like build redundancy and oversight. If system fail, what has to be done? It is supposed to be in the clear written protocol. And this is our December month event. So we are in 12th December. So next Friday on 19th, we have the rerun webinar on emotional intelligence. And on 26th, no webinar. And this is our online CNE. And then about this to 17th December and 24th December, again, we will share you the flyers in the WhatsApp group related to IPC webinar and the masterclass on communication. And here again, many of our participants are now used to like how to get the certificate after attending to this webinar. But still, I think many or a few are having a doubt in how to obtain it. So tomorrow after 4 p.m., check your mail ID. So you would have received the mail from Skills Format. So that's the feedback link. You will receive it. You click that feedback form and then fill it. So in less than 10 minutes, you will receive your certificate. So here in this webinar, during this webinar in the chat box, we will not put any feedback link. So you have to wait tomorrow after 4 p.m.
Technology at work.
Yes. And so we are open for the questions. So here, meanwhile, during the Q&A session, you have two QR code here. One is to join our WhatsApp group. So you have to join our WhatsApp group, can join this WhatsApp group so that you will get the regular updates from us. So this is the QR code to join our WhatsApp group. And also, this is the QR code to join the infection control nurse course program, where the offer sale is running, where I did the announcement in the beginning. So two QR codes are live here. So make benefit of that. And let us move to the Q&A session. If anyone has any questions, you can directly ask here, raising your hands, or you can drop your questions in the chat box. So in the chat box, doctor. So in fishbone diagram, categories like man and method stay fixed, only the details change, or what?
Yeah. I mean, basically, it is categorizing the various causes. As I said, it could be man, machine, or it could be person, process. So you can choose whatever you want. But once you make that comprehensive, maybe 4 or 5 headings, then the causes under that will change for each and every incident. So some people use P, some people use M. It's up to you. You can use any one of those. Both of them are comprehensive. So they will be fixed, and the causes will and each of these heading will change according to the incident. I think that's
I
only
am joining, ma'am, so where you're going to join?
probably one of your courses
Yeah,
which you announced. Yeah.
yes.
I
So
think
you
you should.
can send us the detail to the number which is mentioned here. Jayanti, like you can post your number again. Okay, is it necessary to have both critical value register and separate form to receive critical value from lab?
The critical value register is in the lab, right? So that's a register where you know put the patient's name, what is the value which is in the critical range, and whom, when was the result obtained, when did you inform, who was informed, all that will be in the critical register, critical lab register. Whereas the you don't need to have a separate form to receive critical values. It can be as a part of the case sheet. But again, to have a record of when you received the report from the lab, when did you inform the doctor, and when was the treatment initiated, these could either be evident in the case sheet, or if you want to increase the work of the nurses, you can put another form there. Usually, many hospitals don't do that. They only will, keep acting on the critical lab results and document it in the case sheet. I think there's been a person's hand up for some time. Can you find out? I think two people have raised their hands.
Yeah, yes. I think Manjula and Pradeep Bats.
Yeah, you can ask them to unmute, and
Yes.
they want, they can ask the doubts or whatever they want to ask. There's
Yeah,
called Pradeep.
yeah. Manjula, we have given you the access. You can unmute yourself, and then you can ask your question directly here. Yes.
Okay, looks like
No, she have unmute herself, but
I can't hear anything.
yeah. Pradeep, what's? Might be it was by mistake.
Yeah.
Okay.
Okay then.
Okay.
There's another question in the Q&A by Ashar.
Okay.
Can we maintain register or Excel sheets? Which one is better? I think it's for you, it says ma'am.
Yeah. So I would say you can see if your nurses are very well versed in doing the document in Excel sheet, but Excel sheet is best way than the register. So you can have a track, you can filter, and you can view easy easily you can filter it, and you can view your patient's reports, everything. So you can have it in Excel. If your nurses are finding difficult to use the system, then you have to maintain the register. It's the convenience.
Yeah. The other person asking about the critical register columns. Please download our free, not free, sorry,
Yes,
our
yes.
handout.
Handout. So
It is
there are
almost free,
details.
I would say, almost free.
Yes.
And a lot more details will be there about this critical lab results. We put together a lot of information. All the systems required for critical lab process is there in that handout. I think the QR code you could have put in the end for that also.
Yeah.
But anyway,
Yeah, thank you for joining our WhatsApp group, Nagamanikam.
all right, can I leave? I got
Yes,
some.
yes, doctor.
Yeah.
Thank you.
Thank you.
Yeah.
Thank you so much. Again, thank you everyone for joining us. It really gives us the enthusiasm to keep doing this every Friday. Thank you so much. We'll see you again next Friday. Bye.
Yes. Bye. Thank you so much, sir. So dear all, yet you're already in the WhatsApp group, and and you you don't you have completed your work in this live page. You can leave the Zoom room so that we'll have an understanding to when to close this Zoom meeting entirely. Thanks for all your cooperation.